Living and Learning with Disabilities is brought to you by the Natural Care Wellness Center, which has been serving the seacoast of New Hampshire and Maine for 24 years. Our goal is to encourage a healthy lifestyle through education, wellness choices, and hands-on healing. Natural Care Wellness Center offers gentle force chiropractic, family and child wellness, chiropractic acupuncture, holistic nutrition, nutrition response testing, a decompression table, therapeutic exercise, whole food supplements, neuro-emotional techniques, and massage therapy.
One Sky Community Services, one life, endless possibilities. Incorporated in 1983, One Sky Community Services is dedicated to assisting people with developmental disabilities or acquired brain disorders to live as valued and participating members in their communities. Today, One Sky serves over 1,200 individuals and families throughout most of Rockingham County.
Welcome to Chloe's Shred Shed. I started this small business because I love shredding. I am proud to provide a valuable service in my local community. Being an entrepreneur made it possible for me to keep working during the pandemic. I like working and having a purpose.
Dr. Remignanti's book is based on his 40 years as an emergency medicine physician and 50 years as a chronic autoimmune disease patient, involving 15 hospitalizations, 7 abdominal surgeries, and a major stroke at the age of 38. His book is an extended science-based argument for the enduring importance of the patient-physician relationship, which is in danger of being replaced by the more expensive and less effective consumer-provider model.
Sometimes we miss all those wonderful qualities that we just listed in that last song because we decide who people are before we even get to know them, based on maybe what they look like, how they talk, what kind of clothes they're wearing, what kind of music they like, whatever. We decide who they are before we ever get to know who they really are inside. And it happens to us too. Sometimes people decide who we are before they know us. I think all we really want is just for people to see us for who we really are. See me beautiful, look for the best in me. It's what I really am, and all I wanna be. It may take some time, it may be hard to find, but see me beautiful. See me beautiful, each and every day. Could you take a chance? Could you find a way to see me shining through in everything I do and see me beautiful? See me beautiful, look for the best in me. It's what I really am, and all I wanna be. It may take some time, it may be hard to find, but see me beautiful. See me beautiful, each and every day. Could you take a chance? Could you find a way to see me shining through in everything I do and see me beautiful? Thank you. Allison Decker.
We're back again, my friends. I was thinking when Red was singing that usually we have a guest that may appear to one segment of the population, elderly, young, people with a specific malady or test in life. But I think when Dr. Drew speaks to about the interactions between a patient and the family doctor, a connection that's fraying, to say the least, in modern times, is maybe our most important guest ever, I think. So, but you don't want to hear my voice, but I want to also say we have John Lovering with us and Wendy Chase, good friends. We've been together for so long, you know. It's wonderful. So, Dr. Drew, you don't need me blathering at you with it. You can just say what you want to say, and then we'll break in with some questions.
Well, I found when I finished my career, I was quite alarmed by the trajectory that U.S. healthcare was taking. We spend so much money in the U.S. on our healthcare, more than twice as much as most of the other modern market economies in the world. And yet we have the lowest life expectancy, which is caused by, we have the greatest number of preventable deaths, suicide deaths, and overdose deaths. And what we're looking, one of the unfortunate things we're looking for is a biomedical solution to what really are biopsychosocial problems we have. We need to broaden our concept of what healthcare needs patients have. So I tried to address that in my book. I was alarmed at the trajectory, but I was, in the research I did in preparation for writing my book, I found some hopeful things, which I'll mention at some point.
Oh, good. Hopeful is good. As it is. It's a mess. It's a lot to navigate.
Oh, yeah. No, give us an example. Give us an example of what you went through so we can relate to it. The non-doctor, the non-professional on the street, where it goes wrong, you know.
I titled my book The Healing Connection because I think interhuman connection has a healing power within itself, even outside the healthcare environment. There's multiple evidences of that. I think that it's most powerful within the healthcare environment because the patient-physician relationship is the only one that's really unilateral. It's directed towards your health, you know, and so you have another human being there who's totally committed to maintaining, preserving your health. And so that's why I think makes it uniquely powerful. And unfortunately, in the US, that patient-physician relationship is being replaced by something that is easier to generate money from, which is make the patient a consumer rather than a suffering individual, and make the physician a provider, as if any person can play the same role that a fully trained science-based physician can. It's understandable because it's an easy business model to say, well, gee, the most number of patients we can get through a system as consumers with whatever provider we can provide for them, the more contacts are made, the more bills can be generated, the more money can be charged, the more money can be earned. And that mindset is really corrupted and taken over medical decision-making in the US, unfortunately.
Is it totally negative, or is there any good part of this at all that could be preserved?
Well, one of the things, the most hopeful thing about my book is there's many things we can do as individual patients that can change that, as in terms of how we choose to deal with our doctors. But one more comment on the negative side before I get to the positive stuff. When I was doing my research, I came across this quote, which just delighted me to come across, scared the heck out of me as well. It was in a business journal in which the person being interviewed was the CEO of a $1.5 billion healthcare system. And she was asked by the interviewer, what's one conviction in healthcare that needs to be challenged? And she starts off immediately by saying that the idea that patients need primary care doctors. And she goes on to talk about consumer-driven wants, and then concludes that patients need primary care, but not necessarily a physician relationship. I was blown over when I read that. I was actually thrilled to
Really
read it because
shocking. It's shocking.
it was shocking that I mean, who's going to make the decisions then? And it's a brilliant business idea. Let's take the doctor out of the equation and just try to sell services to patients when they're anxious and incompletely informed consumers. It's a brilliant business idea, but it's a terrible healthcare idea. The frightening aspect of it that she wasn't afraid to say it out loud. You know, I was thrilled. I have a number of quotes like that.
Oh my God.
They're not trying to hide the fact any longer that they want us to be anxious, incompletely informed consumers. That's sort of understood that that's who they're dealing with. Unless we get the doctor out of the picture, you know, we can convince them that they want total body MRI scans, which apparently now you can order on your own if you want. There's all kinds of healthcare services you can order without a doctor that they're trying to convince you that you need. Both here in Portsmouth locally, and I was in Buffalo over the Thanksgiving weekend. I saw several shops where you can go in and you can request intravenous infusions of vitamins, or I don't know why I didn't look at their whole menu of things that you can order without a doctor's order. And my concern is that patients will start to consume things that buy and expose themselves to things that are potentially harmful. And we need the guidance of a trained physician.
It's too complicated for the average individual. I don't care how smart you are. I mean, I'm looking at people that I know are very smart, my friends, and
on the flip side, I'm not advocating.
Yeah.
I'm sorry to interrupt you. On the flip side, I'm not advocating that patients play a passive role in their healthcare. In fact, I'm saying just the opposite. They need to take a fully informed, active role, and that's why I call subtitle of my book is a partnership for your health. It needs to be conceived of as a partnership where you're as fully committed to the process of getting you well as I am, and that study after study shows that that works. If you come in with that attitude that I'm going to take some degree of control, not total control over my healthcare, but I'm going to play a more active role. Patients who decide that, they become more knowledgeable about their healthcare. They become more engaged in the planning of how they're going to address their healthcare needs. And here's the kicker. They reduce their mortality rate in half if you're more fully engaged and patient. You become more adherent to the healthcare plan, and you have a 50% lower likelihood of dying. That's a pretty good payoff. If it was 5 or 10%, you'd say, oh, that's interesting, but ho-hum. But I quote study after study showing that the mortality rate is reduced by half.
So when you tell your colleagues this, what do they say?
Well, as I was coming across these studies which show this again and again, I was thinking to myself, well, why don't we hear more about this? And I think the reason we don't hear more about it is because they're soft issues. They're not the science. The studies that show this are hard science-based studies, but the things they're studying are kind of soft. Like, how do you study whether people are adhering to medications or not? Well, apparently you can if you set them up with pill containers in which, when they open the pill container, you know, there's an electronic record that the pill container was opened. And but nobody can make money off of you if you take more of your medicines. So you can't have the pharmacy calling you, hey, Ronnie, we noticed that you're refilling your medicines on time. That implies to us that you're taking all of your medicines on schedule. Therefore, we're going to have to add a surcharge because you're taking your medicines on schedule. There's no way to monetize it, so nobody is jumping up and down about it.
Hmm.
I can't hear you, Ronnie.
Ronnie,
you're muted.
I'm sorry. Is there a way to monetize it in a good way, or is it hopeless?
I think it's hopeless there's no way you can charge people because they're better patients. You can't charge patients. In fact, if you got really cynical about it, you would say it's in the better interest of the system if you remain a bad patient, because the less adherent you are, the sicker you're going to get, the more likely you will to be hospitalized. So I don't think anybody is promoting that, but it's the opposite of the monetizing. But here's two
I'm
other.
thinking that I should go into my primary physicians, Dr. Davies, a wonderful guy, smoking a huge cigar. And he would pat me on the back and say, Ronnie,
Good
you're
work.
just a wonderful patient. Keep it up, buddy.
Keep up the good work.
The next box of cigars was on me, you know.
I gravitated towards studies in my book that where the endpoint is mortality, not because I'm death obsessed, but it's the hardest endpoint you can get, and nobody can. Some studies are built around the fact of the patient report of feeling better, which is a very subjective thing. But if you're either alive or dead at the end of the study, there's no harder data than that. The two other areas, and besides becoming more knowledgeable and adherent patients, there's two other avenues in which we can affect our mortality. And one is which I just call it connectedness. And that's why it's called the healing connection. Study after study shows that patients who have more social contacts, in the case of men who have the fewer social contacts have 2.4 times the likelihood of mortality than men with more social contacts. And for women, it's 2.8 times. That's something that you don't need the healthcare system to help you to do. You can become more socially active and have more social contacts.
And, yeah, of course, yeah. But then we've come to the COVID years, and some of those COVID habits, you know, are still with us. That sense of isolation that was foisted upon us by, you know, maybe rightfully so, because it was a deadly disease. But boy, it's hard to get out of the culture now.
It is. And here's the interesting thing. I thought, as a skeptic and a hard science guy, I said to myself, well, that's easy to explain. Those people who have more friends have more likely to have somebody come by and check on them. So if you're sick in bed with a pneumonia and you can't get out of bed, somebody's going to knock on your door and say, you haven't seen Ronnie in a while, let me go check on him. Or if you've fallen down the steps and fractured your hip, you're lying on the floor, which we do see in the emergency department from time to time. We see people who might spend a day or two on the floor before somebody finds them. I thought, well, that's easy enough to explain. People with more social contacts are just going to be found earlier. But it turns out that it doesn't have the mortality rate improvement is the same whether you are living alone, whether you are socially isolated, or whether you simply just feel lonely. If you just simply feel lonely, you're at greater risk of dying. So it doesn't really have to do with being discovered earlier. It's that sense of isolation and loneliness in life, which there's no medical solution for it. Again, how can you monetize that finding? You can't say, Ronnie, I noticed on Facebook you have a lot more friends than most people. We're going to have to charge you a surcharge for your health because you have more friends. I mean, there's just no way to monetize it. But that's why. Plus, it sounds soft. You know, it doesn't sound hard science, but it's backed up by hard science studies, and I have all those studies in my book.
Well, maybe I can monetize it. I can go to my friends list and say, look, if you want me to be my friend, it's going to just cost you $5 a month. I wouldn't rob them blind, but
you know. I mean, Facebook monetizes it, of course, but I mean, a good way.
Yeah.
And then the third avenue, which was, so those are two things you can decide without any input from your doctor or the healthcare system. I'm going to become a more knowledgeable and adherent patient. I'm less socially isolated. It takes a little bit of time and effort to be friendly enough to make friends. So that's some effort on your part.
Could you make basic pamphlets, simple pamphlets to get across your ideas? I know I've said this before, but I would love to have something in my hand to like give to somebody where you can just put it on the site and then we could order them. People could order them. I mean, am I wrong, guys? Wendy, John, wouldn't you like to have a pamphlet like this to give to people, your friends?
With the negative things about healthcare?
No, about the good things, about the good parts.
Okay. Being social and yeah,
not that, you know, loneliness by itself can decrease your lifespan. Did you know this before he said this? I didn't. I know he probably talked about this last time, but I mean, I don't know of anybody who knows what he knows. I don't. I know a lot of intelligent people, but I don't know people to know this. That you may not feel like being social, but it is critical to your own health to be social. I know what you went through, Wendy, with tragedies of your life, that you probably didn't want to be social, but you just,
well, you know, I'm sorry, the whole time I have to admit I was thinking about my daughter and Yeah, just how the human touch was so important. And a lot of times I would be so frustrated that I didn't. She'd want to be held and I wouldn't hold her. And I'd give anything to be able to do that again. But it also taught me how important human touch is. And when you don't have it, and like you're saying, or being social with other people and just having that interaction, yes, it's devastating to your soul, to your heart, to your whole being. I see that could definitely impact someone's lifespan.
I mean, I don't want John Lovering touching me.
Yeah,
Well, that's a different thing.
He always says, in the old days when we'd be in the studio, he said, Ronnie, can I touch
me?
And I would say, no, John, don't ask me.
yeah.
I want a hug. No.
Ronnie, you charge me $10 a month to be a friend.
Oh,
You said
Well,
five.
the rate's going to go up, inflation.
That's right.
Expensive.
I've got a question that I made some notes here as I went through your book, which I hope they're doing well with that, because the information in it, with the medical problems I've had since I was 35, I've met an awful lot of doctors, and I found some that fit both of the models that Drew mentions in here. But one of the things that I was really surprised about was about talking about burnout, the suicide rate among physicians. Um, that blew me away. It's one of the highest in the country.
It is the highest. It's the profession with the highest suicide rate in the country. It used to be dentists back when I was in medical school.
right.
But we passed the dentist now. We're number one physicians for the highest suicide rate. It's understandable because we're trained to serve people and to try to relieve suffering, human suffering, and yet we're placed in an environment in which the things we know need to be done are not recognized and rewarded. What we're rewarded for is seeing patients faster and getting them out of the emergency department, for example, so a new patient can get in. That's what we're rewarded for. Taking the time to find out how you can best serve an individual patient is really not rewarded. And that, I like the term. There's an article written by Wendy Dean and Simon Talbot, and they refer to it as moral injury, which is a term that came about in reference to what soldiers experience in a war setting, in which they're breaking their own moral code by killing other human beings, of course, in terms of a military service. And we are breaking our own moral code in healthcare when we know what patients need and we can't succeed in getting them those things they need. So that's what leads to burnout. You said, this is really an unhealthy environment for me to be in. Every day I have to compromise my principles.
I've seen that, and I've talked to nurses. They go through that too.
Sure.
I'm pretty sure.
Definitely.
This is interesting for me. I've been going to Leahy Clinic since 1983, and for the first time in the last maybe 4 or 5 months, when you make a call there, or even walk around, they've got big signs up that says, our staff is doing as well as we can, and we're being as professional as we can, and we deserve your respect. And, in other words, and when you call on the phone, you hear the same message. So I actually asked some of the nurses, it was when I was in one of the cardiology rooms, and I said, "Is that true? Why is you doing that?" She said, "You have no idea what's happened." She said, it's just been since COVID and stuff, but people call up, and if they can't get an appointment, they yell at us and swear at us or whatever it is." She said, "And we're losing a lot of nurses there." She said, "We're understaffed." And so it's more, it's a cycle. She said it gets even worse. So that surprised me. And um, another question, I don't want to, I mean, I've got 3 or 4 things I want to ask you, or again, that I found in your book that I thought were relationships of adverse childhood experiences in the adult life. We're talking about adults mainly, but when I read that, I said, wow, could you go through a little bit about that?
It's a fascinating group of studies that came out in which they had 7 different questions. Patients who, at an early stage in their life, there was either a broken home, substance abuse, or physical abuse, or emotional abuse in their household, and then they tracked them through life, and they found that I forget the other ones that made up the whole 7. The more that you had of those 7 exposures in childhood, the sicker you were later in life. The sooner you died, and that, so we really, something we need to, again, that's the psychosocial aspects of healthcare. That those effects begin in childhood. And so I quote several of their studies.
That would be that bringing in race and so forth into that. They claim that African American people do not get the same medical treatment that other races get, and then Hispanic and so forth. And their rates of illness and stuff are higher. They die younger. Um, I guess that's all kind of the same thing, right?
All the psychosocial aspects, again, in the statistics comparing us to other advanced market economies, we pay only about a third of what they pay in terms, or invest only about a third of the amount that they invest in the social aspects of healthcare, trying to create social and economic equity and giving people equitable access to healthcare.
Wow.
So race and economics play a big role in your likelihood of having a healthy life.
Mm-hmm.
Yeah, what we're trying to do in the US is trying to shoehorn a lot of psychosocial problems into a biomedical model and saying, well, gee, just go to the doctor, go to the emergency department, and they'll treat the way in which you're not feeling well today, when actually the source of why you're not feeling well is the psychosocial environment you find yourself in.
Wow. I've got some more things, but I want to let Ronnie and Karen, Wendy in there.
Okay.
I see Karen.
Let me make one more comment, because I'm afraid I forget to do it.
Sure,
Talking about the things that affect your mortality, that you have an immediate effect on outside the system. There's a whole section of my book on the results of studies on volunteerism.
Mm-hmm.
Patients who get outside themselves and volunteer in a role to help others, they actually benefit more from that than the people who are being served by those volunteers, studies show. And again, the skeptic, the science guy in me said, oh, that's easy. You're self-selecting for healthy people because only healthy people would be out there volunteering. That's what I said. But I read further and further, and one study put the kibosh on that, because it showed that people who are on worse health status, if they have a worse health status to begin with, they have twice the benefit from volunteering as people who have better health status to get go. There's just basically something about that interhuman connection. The more you can have it, the more you can make it happen in your own life. You improve your health, you improve your mortality rate. And again, something that you don't hear about because it can't be monetized. They can't say, hey, John, we noticed that you're volunteering. We noticed you're volunteering at the Red Cross and then at the Good Salvation, the Salvation Army. We noticed you're volunteering too much, so we're going to have to add a surcharge to your health insurance because you're staying healthy for too long. There's no way to monetize it, so it's just not really being promoted, but it's accessible to all of us outside the system. And all 3 of those things, adherence, social connectedness, and showing, I in my book, I refer to it as showing compassion or showing love. The out-of-pocket dollar cost for all 3 of those things is 0. It doesn't cost you a dime to do any of those things, and yet you improve your health and your mortality.
My wife has been a baby cuddler for, I think, 6 years. She did that, and go every Wednesday. She go spend a couple hours holding the little babies and stuff that were in the hospital, and she always came home in a good mood. So I asked her if she'd want to have another baby, and she said, "Get out of here." But, yeah.
That's true. And John, when I had a bad day once and I went over and I sat on her lap, I felt wonderful.
Yeah.
So
I do have, go ahead, buddy. Go ahead, buddy.
What do you what are your thoughts of some of the solutions for these things? I mean, especially when you were an emergency doctor, I was thinking, how you said it's all about turnover as far as I can see whenever I'm in an emergency room. But yeah, how does that make you feel? And what are your thoughts?
Well, I think from the patient point of view, there's no one-step solution. There's no panacea for the condition we find ourselves in healthcare in the U.S. But I think the very first step has to be, and I think has to be the physician-patient relationship, having one that you trust, something that's mutual. And the nice thing about that, that's within our control as patients. In fact, it's more in control of us as patients than it is for us as physicians. Because if as physicians, if we're not being productive in that manner that they want us to be, they'll fire you. So there's a bigger risk for us to take time with you. But you put more time and effort in as a patient. That's step number one. Somehow, if we get enough people doing that, enough voters doing that, we can try to wrest healthcare out of business interests. That's a bigger challenge.
So what happens? I love my PCP, and I do spend a lot of time catching her up on things I'm doing or how her family is. But for say the average emergency care doctor or PCP that is on a tight schedule, if you have those patients that really want to communicate and connect with you, how do you feel? Does that start making you feel a little edgy, or that you got to get going? Or how would you handle a situation like that with someone that wanted to spend their half an hour that they've got?
I'd say when I speak to medical students about this, I say during the course of your training, you need to define and refine what the standards by which you hope to practice medicine. And you can always revisit them and revise them as you learn more, but you should make a commitment to yourself that once you've refined and defined those qualities that you want to present to patients, don't compromise them. Revisit and revise them as needed, but don't compromise them. And the unfortunate thing is you do put your job at risk. Every single year, at the end of the year, I would have to meet with my emergency department director, who would inevitably say to me, Drew, you could be more productive here. You're not seeing as many patients as your colleagues. And I was miffed by that, because I'd say, gee, I'm 30 years in now. Are you really telling me that I don't have a good insight into how much time a certain thing takes? I had to say this in a way that I didn't get myself fired immediately. And I was a little leery at the end of my career that I might get fired before I retired, which I didn't want to end on that note. I practice medicine in a way in which patients will come into you and say, well, I had 2 heart attacks. And you'll be a relatively young person. That's unusual. So in order to see whether that was true, I would get the old medical record to see, and it would turn out that patient had 2 admissions to the hospital for chest pain, which turned out not to be heart attacks. It's understandable, because the patient's in the hospital, and every single day they're saying, we're doing these tests to make sure you haven't had a heart attack. And the phrase heart attack is probably mentioned hundreds of times while they're in the hospital. So if you're not educated enough, you would go away thinking, well, I had a heart attack. They said the phrase heart attack 3 dozen times. And so they make that mental note. And so when I hear that you had 2 heart attacks, I take the time to go to the medical record to see whether you're giving me an accurate report. And very often I learn it's not an accurate report. Therefore, I don't have to put you in the hospital yet again. But you have to be careful, because I've had patients tell me, well, I died twice while I was in the hospital last time. I'd say, come on, really? And then you go into the record, if you take the time to go into the record, sure enough, the guy had cardiac arrest twice and was shocked and brought back to life. Well, and I don't know that unless I take the time to look in your medical record, which is more time consuming than you would think with these electronic medical records. So that guy who's actually telling me something that's true, he did try to die twice in the hospital and got shocked back into life. So he obviously has to come into the hospital, whereas the other person who thought they had 2 heart attacks don't. So that's time consuming, kind of a long-winded way to answer your question, which is at a certain point, I decide how I'm comfortable practicing medicine, and I was comfortable practicing cautious medicine, and even though it's time consuming. So there's a constant pressure to be productive.
Well, I would rather have a doctor that's going to be like you, to look, because I just was down in Florida with my parents, and my dad has some issues. And it is difficult, because when you ask him a question, he's answering about how he feels right now. He's not talking about, well, a week ago I couldn't do this or that, or this has happened in the past. And so many times, just quickly, we have found in the records that the doctor will write something had happened, but it really wasn't. And it's just like you're saying, well, we got to check for that, make sure you didn't have a heart attack, you didn't have, he walks out thinking, wow, I had a heart attack, and he didn't. And then he relays that message. So what you're saying is it's so important. And again, being advocates for ourselves. It's a pain in the butt to keep all your medical records, but boy, when you got to look back, it really makes a difference. So thank you for taking the time.
I was thinking about, and I know John's got a question, but let me get this before I forget it. But how much does malpractice insurance force doctors into larger groups?
Well, it's a constant issue, malpractice, because mostly we're afraid of making mistakes on people's behalf. So we're afraid on your behalf as a patient that I might be making a mistake, coming to a premature decision or an erroneous conclusion. That's priority concern number one. But there's always in the back of our mind, gee, I'm at risk too if I make a bad decision because you'll turn around and sue me. So that's a constant nagging in the back of your mind, which makes us prone to order more tests and contributes to the cost of healthcare because you don't want to miss anything. I mean, if you and I had a patient-doctor relationship and you came in, let's say you're coughing, I think you this even a more simpler problem in the days pre-COVID, and you're coughing and you're afraid you have pneumonia, and I listen to your lungs and you look good. It really doesn't seem like pneumonia; it just seems like a bad cold. I might be able to say, "Gee, Ronnie, your lungs sound so good, your oxygen level is normal. I don't think we really need to get a chest X-ray," or we might decide together to put your mind at ease by getting a chest X-ray. Chest X-rays are not like adding numbers. When you look at them, it's not always clear if there's an abnormality there or not. And if I'm concerned about you and something looks slightly abnormal, I'm maybe going to put you in the hospital on an antibiotic. But if an alternative way of going that route is for me to say to you, gee, Ronnie, it seems like a simple respiratory viral infection, again, simple in the pre-COVID days. I think we can safely send you home with a cough medicine, but you call me right away. If you get sicker, I'll take a quick look at you. And then if we need to go to the next step, we'll go to the next step. So that's time consuming for you and me because it might mean a second visit. And the easier solution is I just order up the chest X-ray for everybody who's coughing. And some of those are going to be interpreted as maybe pneumonia, overinterpreted as pneumonia. Now you're hospitalized and exposed to the germs in the hospital that are sometimes antibiotic resistant. So a simpler form of medicine that's more appropriate for your condition is easier to do if you know me and I know you and you feel known by me and to trust me that I'm not going to short your care.
Boy, oh boy.
You mentioned in your book that primary care physicians are very valuable, and yet I talked to my primary care physician, and there's a shortage of primary care physicians that not going into the field. What would be, is it because they don't make as much money, or?
That's one of the issues. As it turns out, when the average medical school debt nowadays is $250,000 at the end of your 4 years of medical school. That's what you have in loans. When I graduated in 1980, I had $35,000 in debt, and I thought I'm never going to pay that off. That's going to take forever. It seemed like a mountain of debt. Now it's it's $250,000 in debt, and now you have to decide what specialty of medicine you're going to practice. And if you decide if you're by nature you want to be a primary care doctor, and you look at the data which tells you, gee, I'm going to make $150,000 a year less than the people who specialize, then you get pressured away from primary care, whether it's family practice, internal medicine, or pediatrics. So there are financial incentives to avoid primary care.
Oh my God, that's so scary. Is there any other countries that you think did it right?
It's hard. In a certain point in my book, I have a lengthy quote from a physician in the National Healthcare Service of Great Britain who identifies some of the same problems that I did, which was interesting since their system is financed so differently than ours. Certainly, doctors in the United States make more money than our colleagues in other countries. but everybody in the system makes more money.
If you cannot fly, if you cannot fly, if you cannot fly, I will lift you up and tell you that I love you. If you cannot fly, if you cannot fly, if you cannot fly, I will lift you up and tell you that I love you. As we travel through this life, there is trouble, there is strife, and some days seem dreary and so long. But with courage on our side, there's no need to run and hide. We can lift our wings and learn to fly. If you cannot fly, if you cannot fly, if you cannot fly, I will lift you up and tell you that I love you. If you cannot fly, if you cannot fly, if you cannot fly, I will lift you up and tell you that I love you. Now today may not seem bright, 'cause we cannot see the light, and there's thick black darkness all around. We can soar up to the clouds and ignore the angry crowds. We must lift our wings and learn to fly. If you cannot fly, if you cannot fly, if you cannot fly, I will lift you up and tell you that I love you. If you cannot fly, if you cannot fly, if you cannot fly, I will lift you up and tell you that I love you. And if fate will be our friend, there'll be peace around the bend. No more tears for us to cry. If you cannot fly, if you cannot fly, if you cannot fly, I will lift you up and tell you that I love you. If you cannot fly, if you cannot fly, if you cannot fly, I will lift you up and tell you that I love you. I will lift you up and tell you that I